Corticosteroids, especially dexamethasone, are among the oldest and most widely used supportive care agents in oncology. While they are not anticancer drugs themselves in most solid tumor regimens, their role is essential in making chemotherapy both tolerable and safe. In this video, we'll explore the three main clinical roles of corticosteroids in cancer care: antiemetic prophylaxis, hypersensitivity reaction premedication, and management of treatment-related inflammation. We'll also discuss their side effects, monitoring priorities, and the evolving trends in their use, all based on evidence from leading oncology guidelines and journals. One of the most important uses of corticosteroids in oncology is as the backbone of antiemetic regimens. Dexamethasone, in particular, has been used for decades to prevent chemotherapy-induced nausea and vomiting, or CINV. Guidelines from NCCN, ASCO, and other major organizations recommend dexamethasone in combination with other agents for patients receiving highly or moderately emetogenic chemotherapy. For highly emetogenic regimens, it's typically combined with a 5-HT3 receptor antagonist and an NK1 antagonist. For moderate risk, a two-drug combination with palonostrone is common. These regimens help patients tolerate chemotherapy much better. Typical dosing for antiemetic prophylaxis varies by chemotherapy risk. For highly emetogenic chemotherapy, dexamethasone is usually given at 12 mg intravenously or orally on day 1, often followed by lower doses for several days to cover delayed nausea. For moderately emetogenic regimens, 8 mg daily for up to 3 days is common. These dosing strategies are based on both guidelines and clinical trial data. It's important to note that research is ongoing into dexamethasone-sparing or even dexamethasone-free regimens, aiming to reduce steroid-related toxicity while maintaining effective nausea control. Growing area of research in oncology supportive care is the development of steroid-sparing strategies. These approaches, such as olanzapine-based antiemetic regimens, aim to reduce or eliminate dexamethasone use to minimize side effects like hyperglycemia and insomnia. Clinical trials are evaluating whether these regimens can provide similar protection against nausea and vomiting without the risks associated with steroids. This trend reflects a broader movement toward more personalized and safer supportive care in oncology. Corticosteroids are also crucial in preventing hypersensitivity reactions, especially with taxane chemotherapy agents like paclitaxel and docetaxel. These drugs carry a risk of infusion reactions, which can be severe or even life-threatening. Standard premedication includes dexamethasone, often combined with antihistamines. The classic schedule involves oral dexamethasone given 12 and 6 hours before infusion, but lower dose and weekly protocols are also used. Even with premedication, a small percentage of patients still experience significant reactions, highlighting the importance of careful monitoring. Medication schedules for taxanes are tailored to the regimen and patient risk. The classic approach uses 20 mg oral dexamethasone at 12 and 6 hours before paclitaxel. For weekly or lower dose regimens, 10 mg intravenously at first infusion and 410 mg weekly thereafter are common. Recent studies suggest that lower doses may be just as effective for some patients, especially after an uncomplicated first cycle. However, even with these strategies, grade 3 or 4 hypersensitivity reactions still occur in about 1–2% of patients. Because chronic steroid exposure can lead to significant side effects, several clinical trials are investigating whether dexamethasone can be safely reduced or omitted after patients tolerate initial cycles of taxane chemotherapy without hypersensitivity reactions. Studies like DEXASTOP are exploring these possibilities, aiming to balance safety with minimizing steroid toxicity. This research is especially important for patients who require multiple cycles of taxane-based therapy. Beyond antiemetic and HSR roles, corticosteroids are built into specific chemotherapy and immunotherapy protocols to manage inflammation and immune-mediated toxicity. For example, they are used to control intracranial pressure in central nervous system tumors and as part of premedication bundles in immune checkpoint inhibitor regimens. However, because steroids can suppress the immune system, their use is minimized around immunotherapy whenever possible to avoid blunting the intended immune response. One of the most significant side effects of corticosteroids in oncology is hyperglycemia, or elevated blood sugar. Studies show that 20% to over 50% of patients on steroids develop hyperglycemia, with nearly 19% reaching diabetic levels. This side effect is unpredictable and not easily linked to dose or regimen, making regular monitoring essential. Hyperglycemia increases the risk of infections, treatment delays, longer hospital stays, and even higher mortality, so it's a top priority for oncology teams. Corticosteroids can cause a range of other side effects, including insomnia, mood changes, upset stomach, fluid retention, and increased appetite. Long-term use, especially in regimens for lymphoma, can also impact bone health, increasing the risk of osteoporosis and fractures. Because of these risks, guidelines recommend reviewing bone health and preventive strategies for patients on repeated steroid cycles. Patients are also advised to take dexamethasone in the morning, with food to help reduce sleep disruption. Dexamethasone and other corticosteroids have measurable effects on the immune system, altering peripheral immune cell counts and function. This is especially important when steroids are used alongside immune checkpoint inhibitors, as they can reduce the effectiveness of these cancer therapies. Oncology teams carefully coordinate steroid timing and dosing to minimize unwanted immunosuppression while still providing necessary supportive care. Oncology pharmacists play a critical role in corticosteroid management. They verify dosing and duration for each indication, monitor for hyperglycemia, and assess cumulative steroid exposure for risks like bone loss and infection. Pharmacists also identify opportunities for steroid-sparing regimens and help coordinate timing around immunotherapy. Patient education is another key responsibility, including guidance on administration timing and self-monitoring for side effects. Guidelines for corticosteroid use in oncology are continually evolving. There's a clear trend toward reducing steroid doses and exploring steroid-sparing regimens, especially in antiemetic and taxane premedication protocols. These changes are driven by new evidence and a focus on minimizing toxicity while maintaining effective supportive care. It's important for clinicians to stay updated with the latest recommendations from organizations like NCCN and ASCO. Summarize, corticosteroids are essential supportive care agents in oncology, serving three main functions: antiemetic backbone, hypersensitivity reaction premedication, and anti-inflammatory support. Dexamethasone is the most widely used, with methylprednisolone and prednisone as alternatives. Monitoring for hyperglycemia is a top priority, and there's a growing emphasis on reducing steroid exposure where possible. Pharmacists and oncology teams play a vital role in ensuring safe and effective use of these medications. As research continues, the use of corticosteroids in oncology supportive care will keep evolving. Ongoing trials and updated guidelines will shape how these agents are used, with the goal of maximizing patient benefit while minimizing risks. Staying informed and adapting to new evidence is crucial for all members of the oncology care team. Thank you for joining us as we explored the vital role of corticosteroids in cancer supportive care.